Okay, today we're going to be discussing the principles of gynecology and the physiology associated with the female reproductive system, okay? Now, before we get started, I just want to go through the basic anatomy of the female reproductive system. So, of course, over here we have our two ovaries, our fallopian tubes, our uterus, cervix, and our vagina, okay? Now, the fallopian tube is made up of 4 different sections. We have the fibriae, then the fiblum, the impella, and the isthmus, which of course leads to the pear-shaped uterine cavity, which is made up of 3 layers, the endometrium, myomerium, and the serosa. And of course we have our cervix, we have our internal cervical os, your external cervical os, which of course leads into our vagina, which is made up of 3 layers, the muscular, the mucosa, and the adventitia, okay? So that's the basic anatomy. Now, majority of the female reproductive system originates from what is known as the Mullerian duct, okay? The Mullerian duct is a duct which, of course, as the pregnancy goes on, of course, is going to differentiate into four primary organs. Number 1, the fallopian tube. Number 2, the uterus. Number 3, the cervix. And number 4, the upper, only very important, the upper 2/3 of the vagina, okay? Now, this is very important because there are 7 different types of Mullerian duct defects, also referred to as MDD, Mullerian duct defects, which we're going to talk about right now, okay? The first one is referred to as Mullerian agenesis. The second one is referred to as a unicornuate uterus. The third one is referred to as a didelphys uterus. The fourth one is referred to as a bicornuate uterus. The fifth one is referred to as a septate uterus. The sixth one is an arcuate uterus. And the seventh is a uterus associated with didelphys, DES, okay? Now, Mullerian agenesis, what happens is normally, of course, like every other organ in our body, we have 2 eyes, 2 nostrils, 2 ears, 2 parts of our brain, 2 sections of our heart. So of course there are also 2 Mullerian ducts, okay? Each Mullerian duct is supposed to make half of each part of the female reproductive system, okay? In Mullerian agenesis, what happens is, for whatever reason, really going to discuss this later, but what happens is that both Mullerian ducts do not develop. Therefore, we're not going to develop any of our female reproductive system. Now, these patients, like we're going to discuss later, are going to have a very small 1/3 of a vagina, but that is only because that is going to be default, okay? In a unicornuate uterus, what happens is that one Mullerian duct formed properly, however, the other one failed to develop. So as a result, what's going to happen is we're only going to have half of our female reproductive system. Specifically, and what's very important over here is we're going to have what is known as a banana-shaped uterus. Okay, and that's extremely important. In addition, we're also going to have a small cervix and a small vagina canal if you want to go inside of there. Okay. Now regarding the didelphys uterus, what happens in the didelphys uterus is, thank God, both Mullerian ducts form. However, normally what's supposed to happen is that both Mullerian ducts are supposed to now fuse to make one nice big uterus and female reproductive system. And these patients, what happens is the Mullerian ducts fail to fuse, and because they fail to fuse, what's going to happen is that you're going to have 2 separate, unicornuate uteruses. Very important, each having their own cervix and their own vagina to an extent. Again, we'll discuss later, sometimes it's even 2 actual outer vaginas, not only 2 inner vaginas, okay? The fourth one is going to be a bicornuate uterus. In a bicornuate uterus, thank God, both Mullerian ducts form. They even fuse, however, they only fuse towards the bottom, okay? So, technically, they're going to not, because they're not fusing on top, you're going to have 2 separate horns. However, as they get down to the uterus, they're going to be sharing the same cervix, and of course, you're going to be having the same vagina, okay? Regarding the septate uterus, what happens is, of course, both Mullerian ducts form normally. Of course, they also fuse properly at all positions. However, normally when the Mullerian ducts fuse together, automatically by default, a septum is created over here. Now, normally, this septum is supposed to go into degeneration eventually. However, in these patients, that does not happen, and as a result, these patients have a nice, mechitza straight down the middle of the uterus, okay? Regarding an arcuate uterus is very simple. What an arcuate uterus is really just an indentation. Again, they both form normally, they both fuse normally. However, for some reason, you have an indentation about the fundus of the uterus. Okay? And the 7th type of uterus is a uterus that was associated with diethylstilbestrol. This basically is a drug which makes the uterus appear to have as a T-shaped appearance. Okay? So that's of the 7 different Mullerian duct defects, okay? Now, it's very important, as a doctor, of course, if a patient comes into you with a Mullerian duct defect, of course, they're going to have a lot of questions about fertility. Can they get pregnant? Are they able to raise a family? And of course, as a doctor, you have to be able to clarify all those questions, okay? So the first thing we're going to talk about is actually how to recognize and how to diagnose a patient with Mullerian duct defects, okay? So the first thing you have to understand, again, before we discuss the different signs of the defect, we first need to understand really how to diagnose. So basically, all Mullerian duct defects are going to be diagnosed really with an MRI as well as an HSG, which stands for histosplengogram. Okay, we're doing this obviously number one because we want to see obviously what exact Mullerian duct defect we're dealing with, but in addition we want to see the extent and severity of the anatomical defect. Okay, so we're going to do MRI to diagnose, and as well as you're going to do an HSG. In addition, we're also going to do an IVP in these patients. Why? Because unfortunately a lot of times patients with Mullerian duct defects usually have some type of congenital renal abnormalities. So it's important to really make sure that the urinary tract is really intact. Okay. So the workup is MRI, HSG, and of course to do an IVP. Okay. And of course, if you ever do more invasive, let's say renal procedures, of course you would do it as abbreviated. Okay. Okay, now let's discuss each one of these. Okay, so Mullerian agenesis, again, we're going to be discussing that later on in gynecology. When we deal with the different type of amenorrheas, we'll discuss how it presents, how do you recognize it, how do you treat them, how do you diagnose these patients, okay? Regarding unicornuate uterus, what happens in these patients, let's say Mrs. Johnson comes in, typically, usually what's going to happen is at the onset of menarche, which is about 12 to 12 and a half years old, what's going to happen is that these patients, number one, and the first hint of a person might have a unicornuate uterus is they might have what is known as hypomenorrhea. Hypomenorrhea, of course, means they have very little menstrual bleeding. And of course, this is because of, like we're going to discuss later, menstrual bleeding is going to be fully proportionate to the amount of endometrial tissue you have. Okay, now because these patients only have half a uterus, technically, so they only have half endometrial tissue, that means they're only going to be menstruating half, okay? So that's why the patients have hypomenorrhea, okay? In addition, and this has to do with all Mullerian duct defects, and this is extremely important, history of some type of obstructive complication, okay? They can have many complications. They can have, premature labor. Yeah, the premature labor. You can have stillbirths. You can have miscarriages. You can have abortions. You can have breech presentation. Every single obstructive complication in the book, these patients have. You can have IUGR, okay? So a history of obstructive complications should make you suspect the patient may have some type of Mullerian duct defect. And of course, when you suspect that, you take the MRI, the HSG, and you'll see exactly which one of these defects the patient is going to be having, okay? Now, in addition, what's very important about a unicornuate uterus is it has to do with this banana-shaped horn, okay? This horn actually can be very, very, very problematic. If a patient gets pregnant, okay? If a patient gets pregnant, let's use a different marker. If a patient gets pregnant and the pregnancy occurs within this horn, okay? Then what's going to happen is that this pregnancy, and a lot of times, can lead to uterine rupture, okay? And of course, that can be very dangerous for the mother as well. Of course, the baby is going to die. So unfortunately, the protocol is, if a pregnancy is associated with the horn of the uterus, what you're going to do is you're going to remove the horn even with the pregnancy, okay? I know it sounds dangerous, I know it sounds, very crucial, but again, we have to look out for the mother. It's very life-threatening to the mother, and you have to remove the horn, okay? In addition, let's say a patient has a unicornuate uterus, and of course she has this banana-shaped horn, but let's say she wants to tell you, you know what, doc, I don't want to get pregnant. Can you still leave her be? And the answer is, that actually depends. If within this horn, you're going to have viable endometrial tissue, so if there is normal endometrial tissue, because if there's endometrial tissue, unfortunately, a lot of these patients develop endometriosis, as well as develop what is known as hematometria. So in those situations, of course, you're going to have to go and remove this type of horn, okay? However, in situations where there is no viable endometrial tissue, then technically you can let it be, because you don't have to be scared that they're going to get pregnant there, because obviously there's going to be no viable tissue over there, okay? Now, so let's say a patient, and let's say Mrs. Johnson has a Mullerian duct defect, she has a unicornuate uterus. How are you going to approach her? Well, number one, again, because she's at risk for all these obstetrical complications, you have to constantly follow up with your patient. Of course, if for some miracle, let's say she goes and she survives the, and goes very long-term birth during this pregnancy, of course, she's going to want to know if she's able to do a regular vaginal delivery, of course, or she may have to have a C-section, okay? And the answer is, if they ask us on the board, you're going to have a C-section in these situations, okay? And the answer is remember, because she only has half endometrial tissue, so what's going to happen is she's only going to have half myometrial tissue. And of course, myometrium is required to pull and push, get the baby out of there. So because she only has half that force, therefore, it's going to be very, very hard. The patient's going to have a very bloody and very prolonged, contraction labor. and of course can be very life-threatening for the baby as well as for the mother. So protocol is just to do a C-section, okay? So that is a unicornuate uterus, okay? Now regarding a didelphys uterus, remember didelphys uterus is when the two uteruses go and they basically go and then really separate chambers, okay? Now these patients actually present very, very, very unique. What happens is, for example, what happens a lot of times is, let's say a mother comes in with her 16-year-old daughter, and they're very, very concerned. They're not understanding what's happening. Of course, when she gets her period, she goes, she puts the tampon in, and yet, she checks it over and over again, but still, for some reason, blood is still coming out of her, although they're, putting the tampon in right, okay? Now, of course, before you suspect that a patient might have a didelphys uterus, of course, obviously teach them how to do it. Of course, the mother obviously helped her, she knows how to do it, but if this keeps on happening, despite putting in a tampon, still seeing menstrual blood flowing, then you should suspect a didelphys uterus. And the answer is, it's because she has two vaginas, technically. Again, technically, depending on, where it could be an external one, it could be an internal one, but let's say this is an internal one, because technically she has two of them, so she'll obstruct one of them with the blood, therefore blood won't come out of that one. However, because basically there's still another one not being obstructed and still has an opening, technically she will see blood flow, okay? So one of the patients that presents with you is going to be, I don't know how to say this, but having periods. Periods despite tampon, whatever that means, okay? Okay, so that's the first way to, diagnose these patients. Another way to diagnose these patients, of course, except for the family history, also, what happens is in didelphys uterus is that you can have what is known as a complete closed vaginal septum, okay? What happens is that the vaginal septum will go and obstruct this entire outflow. Of course, she's able to pee and stuff. However, regarding the menstrual blood, of course, she could have an obstruction over here. And again, we'll discuss later on the complications of a complete vaginal septum. Of course, besides the fact that she's going to be amenorrhea at the time of menarche. In addition, she also might have what is known as hematosalpinx, hematometra, and hematocolpus, as well as cryptomenorrhea. Again, we'll discuss this later. Just note that these symptoms are also common in patients with a didelphys uterus. Okay. Now, regarding conception, reasons. Again, this really applies with a bicornuate uterus unicornuate uterus as well. Technically, because again they have normal ovaries, they're having normal ovulations, whatever it is. Technically, they're going to be, sperm can get up very easily and go and fertilize the egg normally. Okay, and even regarding plantation, they can even go and implant itself normally. The problem is because there's such a small uterus, because there's not in this one, because there's not a lot of endometrial tissue, it's very hard for the baby to really survive. Okay, so therefore the baby usually will just get miscarried within the first couple of weeks. Okay, regarding a didelphys uterus, of course the same thing happens. The uterus is misshapen. They have risk for all unnatural complications. So of course during the pregnancy, these patients always, of course, has to be constantly monitored as well. Okay, and that's regarding with all uterine defects. Okay, now regarding the treatment, try avoiding vaginal deliveries. Again, if she really is doing perfect, technically she can technically do a vaginal delivery. But again, the best, if they ask you on the board exam what to do, is going to be a cesarean. Okay, and that is the bicornuate uterus. Okay. Also, bicornuate uterus, technically, I forgot to mention, you technically, again, like I said, depending if this is an external vagina or an internal, didelphys vagina, what happens is you can technically go and live within one of them, have intercourse in one of them, and go and impregnate the first uterus, while 10 minutes later going to the other one and impregnate the second uterus. Okay. Now, in those situations when you have two uteruses, both pregnant, I'm sure they're not going to ask that on the board. That's way above your specialty. But again, you'll just go and send her some specialist which specializes in these poo-poo fertilization cases, like a fertilization in the abdomen, like those type of gynecologists and those types of OBs. Okay. Okay. So next is going to be the bicornuate uterus. Okay. Bicornuate uterus, there really isn't any significant distinct symptom which you'll be able to say, oh, okay, that's bicornuate uterus, except the fact that, of course, they might have some type of history of sexual complications. Now, I have to admit over here, a bicornuate uterus actually is going to be a very mild of almost all the uterine duct defects. I mean, it's typical for an arcuate uterus, which is going to be actually the least of the mild, and it's going to be the least severe in terms of sexual complications from uterine duct defects. A bicornuate uterus is really second in charge over that. Okay. Again, the same thing you're going to do. These patients, however, still are at risk of sexual complications. So of course you have to do constant checkups These patients regarding the delivery method, because technically they have full endometrial and myometrial tissue, so of course you can do vaginal delivery, but again, if complications arise, obviously, then you're going to do a C-section, okay? Now, regarding a septate uterus, if you don't have any uterine duct defect, the worst one to have is a septate uterus. Septate uterus actually is the most severe of all the uterine duct defects in terms of fecal complications. It's very, very, very hard to get pregnant with a patient and a person with a septate uterus. Unfortunately, these patients, instead of, wasting time and money, if a patient has septate uterus, go straight to metroplasty, okay? Just go and fix up the uterus, okay? Now, regarding metroplasty, I forgot to mention before by all the other ones, metroplasty is going to be the choice that you're going to answer if you tried all other ways. You tried giving the progesterone, you give all the healthy things, trying to, really, the clomiphene, the beta-HCG, the progesterone, all that type of stuff, and still, despite that, the patient still doesn't get pregnant, then you're going to go and you're going to fix up the uterus, you're going to do a metroplasty, okay? And again, like I said, this is the worst of the obstetrical complications, and go straight to the metroplasty. Regarding an arcuate uterus, again, like I said, is one of the most mild of all the obstetrical complications. Technically, you could do a vaginal delivery, and there really is going to be no problem over here, okay? Also, regarding the septum uterus, again, vaginal delivery, technically, again, when someone randomly gets pregnant, technically, there's not contraindicated to do vaginal delivery, okay? But of course, regarding all of these, again, if any of the situations which is contraindicated to do vaginal delivery, then you're going to do a cesarean, and this applies to all of these, okay? And regarding a uterus associated with dithiostolbesterol, well, let me just speak about this for a second. Dithiostolbesterol is a drug we don't use anymore. It's associated, number one, with a T-shaped uterine cavity, as well as associated with different types of, cancers, specifically cervical and vaginal clear cell adenocarcinomas. Okay, so in case they ask that, we don't use this anymore either way, and you're probably not going to ever have a patient with a uterine duct defect that is associated with DES. So it's really not even worth talking about. Okay. Okay, now before we get into actual clinical gynecology, I first want to quickly go through the embryology of the male reproductive system, because like we're going to see later, it's actually going to come and it's going to correlate with clinical gynecology, okay? So in order to understand the embryology of the male reproductive system, you have to understand the rule, okay? The rule is automatically by default, the way God made us is that a baby automatically by default is a female, okay? If you let the baby grow the way it is, it's automatically going to be female unless two things happen. Number one, we have to actually make the male reproductive system, and number two, we have to prevent the females from growing, okay? And let's discuss how this exactly happens, okay? So of course, if a person's a male, on the XY chromosome, of course on the specifically the Y chromosome, there's going to be a very important gene known as the SRY1 gene. Okay? Now this gene is very important because it's responsible for synthesizing a protein referred to as TDF. TDF stands for testicular differentiation factor. Okay? Now TDF normally is supposed to go to the what is referred as the undifferentiated gonad. This undifferentiated gonad can either become an ovary or become a testicle. Okay? Depending on what are the factors. Okay? If TDF stimulates it, it's going to go and it's going to become a testicle. Okay? Now once the testicle is formed, of course there are two cells in the testicles. You have the Leydig and the Sertoli cells. The Leydig cells will release what is known as testosterone. Testosterone will go and it will form in the male reproductive system three very important structures: the penis, the prostate, and the scrotum. Okay, and of course later on testosterone will be converted to dihydrotestosterone, DHT, and of course that's going to make another three very important organs. Number one, the vas deferens, the seminal vesicles, and the epididymis. Okay, so that is how we make our male reproductive system. We have TDF stimulating the testes to form the testes. Testosterone, dihydrotestosterone will make our male reproductive system. Okay, so we got the first part taken care of. Now the second part is now again we still have a Mullerian duct. Okay, so our Sertoli cells will take care of that. Okay, and they're going to release what is known as MIF, Mullerian inhibiting factor. Okay, and MIF is going to go to this Mullerian duct, and basically, specifically, it's going to activate the apoptosis factors within the mesenchymal Mullerian duct, and of course, this is going to go and it's going to kill the Mullerian duct. So of course, that is how we make a normal male. We make male reproductive organs, and of course, we inhibit the females from growth. Okay, and that is the male reproductive, and that is the embryology of the male reproductive system.